السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. أنا دكتور ماهر غزاوي، مشرف خدمات الأشعة في التجمع، بادي إيمجنج كونسلتنت في مستشفى النور التخصصي. حياكم الله جميعا، سعيدين بتواجدكم مرة أخرى، وكل عام وأنتم بخير وعشرة مباركة إن شاء الله علينا وعليكم. ربي يجعله إن شاء الله موسم ناجح وآمن و يعني يسبق جميع المعايير السابقة بإذن الله. ويبارك في الجميع إن شاء الله، ويبارك في جهودكم. كل الشكر للزملاء اللي حاضرين اليوم معنا من جميع مستشفيات التجمع اللي مكلفة بالعمل في موسم الحج. آه، قبل ما أبدأ أحب أشكر جميع رؤساء الأقسام، الله يعطيهم الصحة والعافية، اللي الشيء اللي لمسناه خلال متابعتنا الدورية خلال الأسابيع الماضية، وجاهزيتهم التامة الحمد لله لاستقبال الموسم. ربي يوفق الجميع، رؤساء الأقسام ونوابهم وجميع الستاف اللي بيشتغلوا في مستشفيات المشاعر ومكة المكرمة. وكل الشكر للزملاء معنا في فريق الأشعة، فريق الإشراف على الأشعة، وفريق الفيزياء الطبية بتجمع مكة. الله يعطيكم الصحة والعافية جميعا. Inshallah, we will start a series of lectures regarding the excellence of operational topics in radiology department. We will start today with the first topic, talking about the importance of turnaround time for the emergency requests. طيب نبدأ بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على سيدنا رسول الله وعلى آله وصحبه ومن والاه. I will talk briefly, inshallah, in 30 minutes about the radiology turnaround time during Hajj season. The objectives, inshallah, we will, at the end of the lecture, everyone will be able to understand the importance of compliance with the MOH radiology turnaround time target. We will recognize the relationship between the delayed imaging and patient safety risk, and we will identify the practical strategies to reduce the turnaround time of emergency requests. And we will learn from the previous experience in Noor Specialist Hospital and different hospitals in Makkah Health Cluster. And we will recognize the key operational risk and mitigation strategies. And finally, we will be able to promote sustainable workflow improvement in the near future, inshallah. Okay, these are some keywords. The definition of turnaround time is the time from emergency department imaging request started to completion of the report, of the radiology report. LOS stands for length of stay, is the time from emergency department arrival from door to the deposition of or the decision of the clinical physician. Emergency radiology department is clear. CTAS is the categorization system used usually in the emergency department to categorize the patient into 5 categories: CTAS 1, 2, 3, 4, and 5. Both 4 and 5 are cold cases, and usually no radiology examination needed for those patients in CTAS 4 and 5. Usually, we need to request imaging studies, either X-ray, CT scan, ultrasound, for CTAS 1, 2, and 3. Preliminary report is a rapid initial radiology interpretation to support the urgent decision before the final report. Okay, why turnaround time matters during Hajj? Due to the extreme workload in the emergency department, time-critical patients, and crowded emergency departments in Al-Mashair and Makkah hospitals, and high expectations from the administrative office. And why should radiology care about turnaround time? Remember that radiology delay equals delayed treatment, okay? So for example, if you have a case of a stroke, if your report is delayed more than the expected time, this will lead to thrombolysis delay or treatment delay, and so on. All these are examples, and stroke, trauma, sepsis, acute abdominal, and pulmonary embolism, all these should be considered as a high priority during the mission of Al-Hajj, and you can categorize more cases as high priority in your department and give the priority for reporting for these cases. The MOH expectation and KPI is 60 minutes only. 60 minutes starting from request submission until issue of report. Okay, so the total time, average of total time of whole patient from emergency department is 60 minutes only. So we are expecting 30 minutes from request to image completion and another 30 minutes from image completion to report release, as much as we can. Okay, what happens if we fail clinically? The diagnosis will be delayed and the patient will be clinically deteriorated maybe, and there is a delayed intervention and increased mortality and morbidity risk. Operationally, this will lead to emergency department crowding, long length of stay and ambulance delays and staff burnout in the emergency department, and organizational poor KPI performance, patient dissatisfaction, and there is maybe escalation to the high level in the MOH. So this is one of our trials done before in Mustashfa Noor Hospital. In 2022, we have a great experience with the turnaround time, and we tried our best to analyze the causes and to implement some solutions to reduce the turnaround time. And I will show you the steps, what have been done in Noor Hospital since 2022, and what are the impact or the results of that intervention until today. So before intervention, the turnaround time of CT scan and ultrasound was ranging between 2 and 4 hours. This is from emergency department only, and there is a workflow variability in the emergency department and radiology department as well. As you can see in the diagram, the ultrasound in orange and the CT scan in blue line, there is variability every month between the ultrasound and CT scan, and both are exceeding the expected turnaround time. After root cause analysis, we found that there are 5 main causes that contribute to the delay of the turnaround time. Number 1 is the unnecessary or non-value added pre-imaging requirement. For example, there is a practice in our hospital and some hospitals, there is mandatory routine creatinine test for every single patient. And this is number 1. Number 2, mandatory pregnancy test for each female patient going for emergency department or for radiology department coming from the emergency, and prolonged fasting. Some centers ask for fasting for 4 hours, some asking for 6 hours. All these are causes contributing to delayed turnaround time. And oral pre-medication for allergy patient is disaster, really disaster. Oral pre-medication within the emergency department, it will take more than 12 hours. And finally, the oral contrast and rectal contrast administration for any abdominal or acute abdominal cases. This is number 1. Number 2 was the radiology workflow constraints. There is a delayed final report due to radiologist shortage sometime, competing workload, or high case volume. And also there is a complex or multi-organ cases like pan-CT scan in trauma case. We have multi-organ to be scanned, to be reported separately. We have brain, cervical spine, chest, abdomen, pelvis, and sometimes lower limb or upper limb angiogram. Number 3 is the communication gaps between the radiology staff and the emergency department staff. Inefficient communication between both departments during peak hours is one of the main causes that contribute to delay the turnaround time, and the incomplete or unclear request without clear clinical data, without clear mandatory information. All these are delaying the turnaround time and delays in patient transportation, coordination from emergency department to radiology. Okay, these are the most important 3 factors. And what changed? We have established a fast-track workflow, better emergency department radiology coordination, standardized preparation, okay, removal of all unnecessary delays, and we established the preliminary report to expedite the treatment of the patient. And these are the steps here. Number one, we removed all non-value pre-imaging steps. Here are the details. Routine renal function test is not mandatory. Number two, prolonged fasting, not mandatory also. Universal pregnancy test, especially for any CT scan or X-ray for other organ away from the abdomen and pelvis. For example, chest PE, CT brain. No need to ask the patient to do pregnancy test. You can ask the patient verbally if the patient is pregnant or not. If she is pregnant, you can take your precautions. If not pregnant, no need to do pregnancy test. Just proceed for CT scan directly. The unnecessary allergy premedication. Premedication is not mandatory for all degrees of allergy. If the patient has a previous history of allergy, if it is mild or moderate, premedication is not recommended. The ACR recommendation for premedication is only for the severe degree of allergy for the same class of contrast media. And the routine oral and rectal contrast. Unfortunately, some hospitals still practicing this old protocol for any acute abdomen. They usually asking for oral contrast and rectal contrast and IV contrast for each acute abdominal case. Believe me, acute appendicitis can be easily diagnosed without oral contrast, without rectal contrast. Bowel ischemia, you cannot diagnose bowel ischemia with oral contrast. The oral contrast will obscure the enhancement of the bowel wall or mucosa, and the case will be difficult for you. So you are delaying the case in the emergency department, and your report will be hesitated. You are not sure 100% if there is ischemia or not. Another cases like inflammatory bowel disease, Crohn's disease, no one can diagnose inflammatory bowel disease with the presence of oral contrast within the bowel lumen. So all these steps are omitted from our protocol, and this is regarding the first step. The second step is standardized pre-imaging workflow. There is a unified checklist for CTAS 1, 2, and 3 with clear role assignment between both emergency department and radiology department and fast track pathway for time critical cases. Activation of preliminary reporting, rapid initial interpretation to support urgent decision, followed by consultant verified final reports. If you have a case normal, just write it down, normal, no appendix, no traumatic injury, like that. This brief statement in your preliminary report will help to facilitate and to accelerate the process in the emergency department, okay? Strengthening the emergency department and radiology coordination. There is a direct communication now, direct communication channels between both emergency and radiology staff with real-time transport alignment and high acuity huddles. Implemented continuous monitoring. We have weekly auditing and feedback loops to refine and sustain the improved workflow with the medical director directly and with both HODs of emergency department and radiology department. What are the challenges we faced at that time? The first challenge was the resistance from the radiology staff. Here, how to solve this problem, how to solve this or to overcome this challenge? We have to conduct a focused orientation and clarified workload impact and implemented phased adoption. Okay, we can start with phases. Okay, with this way, you can reduce the resistance from the radiology staff. This is number one. Number two, frequent changes in KPI definition and data sources. Unfortunately, every time we have new KPI, new benchmark, sometimes from health holding companies, sometimes from the MOH, and every time we have changes in the KPI, this is another challenge. Number three, the complex and polytrauma and multi-region imaging requests increase the turnaround time. We introduced the fast track protocols and assigned dedicated technology support during peak hours, especially for stroke cases and trauma cases. Hesitation to use preliminary report. We understand that point from the radiology side and from the emergency side. If we can rely totally on the preliminary report, or there is maybe a conflict between the preliminary report and the final report. So provided reporting guidelines with very clear escalation pathway is very mandatory to overcome this challenge. So you have to have a reporting guidelines in your department, escalation pathway, if any case of conflict or missing from the preliminary report, how to call the treating physician and how to call the patient back, and consultant oversight. Workflow inconsistency across shifts, implemented cross-shift standardization and coordination meetings, and finally, coordination gaps between the emergency department and the radiology department, as we discussed before. What are the risks? What are the risks of having all these steps? Number one, there is maybe increase of demand from radiology, from emergency department, maybe overuse or misuse. Okay, so the proposed solution for this risk is to strict CTAS-based criteria. This is number one. Number two, emergency department to radiology triage alignment. We have to do the triage from both sides, not from the emergency sites alone, okay? And ongoing auditing for request patterns. This is very important. Number two, the second risk is omission of necessary pre-imaging tests. For example, not doing renal function test for high-risk people or pregnancy test for high-risk, for example, situation for the fetus. For example, if you have a case of abdominal CT scan and the patient is not certain or not know if she's pregnant or not, here you have to stop. You have to check for the pregnancy test first before shifting the patient to the CT department. And we have to develop an evidence-based pre-imaging checklist. Okay, all these are mandatory to overcome this risk of omission of any necessary pre-imaging test. The third risk was the communication gap between both emergency department and radiology. We have to conduct a direct communication channels with shared triage huddles and structured handover for high acuity cases. Number four, increased reporting errors under time pressure. Consultant oversight and standardized prelim reporting templates will solve this problem and to minimize the risk of this problem. Okay, number five, conflict between prelim report and the final report, with clear policy defining the scope of preliminary report and mandatory addendum by consultant with very clear escalation pathway. Believe me, with time, everyone will be happy with the preliminary report, and they will rely on that prelim report and will accelerate the process of management of the patient in the emergency department. Finally, the incomplete clinical interpretation. Mandatory clinical summary in imaging request is mandatory, okay? And radiology emergency joint review for uncertain cases should be conducted periodically, either weekly or daily, based on your hospital. So these are the results. After implementing all that previous steps, we start the implementation exactly at the beginning of the second half of 2023. Here you can see very obvious decrease in turnaround time for both CT scan and ultrasound requested from emergency department, decreasing from almost 4 hours down to 145 or 130 minutes. And it was amazing. Great job from the department of radiology and emergency department. And alhamdulillah, we sustained along 2 years now, from 2023 now until the end of 2025, and even in the first quarter of 2026. Okay. And this is the indicator of length of stay in emergency department of CTAS-1 patient. We noticed that there is a sustainability around 70% for CTAS-1 patient completed their journey in the emergency department within 4 hours. So the TAT of length of stay in emergency department from door to this position is 4 hours, including radiology and laboratory investigation. Regarding CTAS-2, there is a sustainable improvement around 65 to 70%. And the main bulk of patient in emergency department, usually the CTAS-3, there is a sustainable improvement reaching up to 80%, alhamdulillah. So impact summary, this is the pre-implementation for both CT and ultrasound. It was exceeding 4 hours, creating delays in diagnosis and treatment, and the length of stay for CTAS-1, 2, and 3 was not reaching even 70%. Okay, this is before implementation of the correction plan. And after implementation, you can see the improvement in turnaround time for CT scan from 345 down to 145. And ultrasound, still, it is not reaching the target. The target is 1 hour, okay? But there is obvious improvement, alhamdulillah, from 345 down to 145, and ultrasound from 330 to 145 hours. Okay, and the length of stay for CTAS-1, we have reached 100%, alhamdulillah, in sometimes, and sometimes going down according to the situation in the emergency department. And for CTAS-2 and 3, the length of stay was stabilized around 70 and 80% for very long period, alhamdulillah. So these improvements reflect safer and faster emergency care, optimized patient flow, reduced diagnostic delays, and strengthened clinical outcomes. So what can we do for sustainability plan? Number 1, integrated workflow, updated pre-imaging steps, fast-track pathway, and emergency to radiology coordination are now part of routine practice. This is number 1. Number 2, standardized checklist, mandatory pre-imaging checklist, especially for CTAS-1, 2, and 3, ensures consistent preparation and reduced delays. And number 3, preliminary reporting. Please, it's very easy, very nice, very helpful. You can start the preliminary reporting strategy in your hospital. Believe me, everyone will be happy. The emergency department will be happy, and even the radiologist will be happy. Once you submit the prelim report, you have now your time. Take your time, interpret the image slowly, focus on the study, okay? And write your finalized report even after 1 hour. It's okay. Once you submit the prelim report, the turnaround time is already calculated, okay? Number 4, ongoing monitoring. All these steps should be monitored frequently from the emergency and radiology HODs or quality coordinators. And regular auditing and feedback is also mandatory to the medical director. And the governance oversight, quality, and patient safety teams ensure long-term compliance. Staff education, ongoing orientation, as we are doing now for new staff, or annual refreshers for existing teams is also helpful. Okay, regarding the scalability and replication in the other hospitals, we have to standardize the workflow, the pre-imaging checklist, fast-track pathway, and preliminary reporting, and so on. Okay, minimal resource dependency. The intervention relies mainly on workflow redesign and staff coordination rather than new equipment, okay? Making replication feasible across all hospitals in Makkah Health Cluster. Clear performance indicator, we have turnaround time and length of stay. These are the main indicators that reflect the performance of radiology department with all emergency requests. Improve patient safety outcome, demonstrated reduction in diagnostic delay and emergency department crowding, support strong justification for wider implementation. Transferable training framework, staff orientation, reporting guidelines, and emergency radiology coordination mechanisms can be standardized and delivered across multiple hospitals within the cluster, inshallah. Okay. After we start replicating this technique or the new steps in few hospitals within Mecca cluster, we found a good, obvious improvement in the overall turnaround time for the average of all Mecca cluster, mashallah, decreasing from 2 hours, maybe, down to 1 hour. Okay, so we are approaching the target. At the end of October in 2025, we have reached 1 hour exactly and 3 minutes. Okay, Alhamdulillah, nowadays, in the first 2 weeks last 2 weeks of Al-Qaeda, we have reached 50 minutes, Alhamdulillah. So it's visible, it's applicable, nothing is difficult. And with orientation, with phased steps, we can reach the target, inshallah. And this is the length of stay across all MHC hospitals. Alhamdulillah, for CTAS 1, 2, and 3, the length of stay indicator stabilized above 85, okay? So reaching 90%, which is very nice and very good. So what can we do during Hajj? Prioritize emergency requests, especially for CTAS 1, 2, and 3. Minimize avoidable delays. Avoid all unnecessary waiting. No need for creatinine or as a mandatory routine test. No need for pregnancy test. No need for fasting. And no need for rectal contrast. No need for oral contrast. And for allergy cases, if the previous history is severe reaction, here we have to stop. But if the symptoms or signs was mild to moderate, no need to pre-medicate the patient, and you can proceed for imaging directly. Number 3, fast communication, direct call between the emergency physician to the technologist or radiologist in the radiology department. Preliminary reporting is a very helpful tool, okay, for urgent cases like stroke, trauma, acute bleeding, surgical emergency. You can write very short sentence, only one sentence, normal appendix, acute non-complicated appendicitis, bowel perforation, for example, and so on. Okay, this is very helpful, very helpful. Okay, it will facilitate and accelerate the management in the emergency. And finally, smart workflow, separate in your radiology department. You can categorize the request to urgent, semi-urgent, and routine. Okay. So Hajj-specific challenges, we have patient factors like language barrier. Okay, this is one of the most important factors, language barrier. Inshallah, tomorrow we will talk how to solve this challenge. Number 2, unknown history. We have diverse pilgrims from the different countries. Not all of them are Arabic or English speakers. So we have, and even medically, none of them, or not all of them, are knowing the medical history or past medical history for their relatives or for himself as a patient. And the other factors like dehydration, this will delay the process of cannulation, process of scanning, and high elderly population. Very difficult to deal with the high elderly population regarding the protocols and the instructions of the CT scan and pre-test requirement. Workflow factors, we have peak surge hours. For example, in Arafah day, I think the peak hours starting from 11 a.m. or 10 a.m. Until maybe 6 p.m. These are peak hours. We have to be careful. We have to be ready. Okay, no delay. no unnecessary requests, just accept the case and start scanning and start give the prelim report. Okay, multiple simultaneous emergencies, transportation delays, and high trauma burden. All these are factors are present specifically during Hajj period. Staff factors, fatigue. Usually, we are working for 12 hours daily for 2 weeks or less. Most of the staff are not able to maintain the effort or the level of effort at whole period of assignment. So you can rotate the staff, especially the technician, between the hours. Every 4 hours or every 6 hours, you can shifting the technician from high burden area to the low workload area, and so on. This is very important, rotating teams and external workforce. We have, Alhamdulillah, in Al-Mashaa'ir only, we have good support from Sahih Virtual Hospital for reporting only, and this will help you a lot, inshallah. Risk of faster workflow, as we said before, may be wrong prioritization, reporting mistakes, missing preparation steps, miscommunication, and over-requesting imaging. How to reduce the risk? Number one, we have to have standardized preparation checklist, escalation, very clear escalation pathway, and consultant support, preliminary report policy, good communication, double check the critical findings, and team huddles during peak hours. This is the suggested Hajj workflow. Once the request is submitted in the system, we have to do our triage according to the urgency, fast transport, give the priority for imaging of the CTAS 1, 2, and 3, and immediate prelim report, and then finalize your report ultimately. So long-term impact for Makkah hospitals will benefits beyond Hajj, inshallah. We will have better patient safety, better emergency department flow, better MOH KPI compliance, and reduce crowding with better staff satisfaction and stronger emergency readiness, inshallah. So take-home message, radiology TAT is not only a KPI, it is patient safety. Number two, during Hajj, every minute saved every minute saved may prevent disability or save a life. Fast imaging plus fast reporting equal fast treatment. And excellence during Hajj starts with teamwork, communication, and smart workflow. What we improve during Hajj should become the standard for all Makkah hospitals along the year. And thank you very much. If you have any question, just raise your hand. And I would like to thank Mr. Ayman Bapour for his great effort for preparing for this webinar and the next webinar. And I'm already done. If you have any question, please raise your hand and happy to listen from you. Thank you very much. Or you can leave your question in the Q&A box. آسف انقطع الاتصال عندي. Inshallah, tomorrow we'll talk about safe use of contrast media, and after tomorrow we'll talk about the importance of post-mortem imaging, post-mortem CT scan. I think Abdullah Zambagi has a question. Yes, Abdullah. أيمن إذا تقدر تفتح له المايك تفضل. أيمن تسمعنا؟
اسمعك دكتور.
أيوة. أعتقد في واحد عنده سؤال تشغل له
ايوه،
المايك.
اعطيته المايك، بس الظاهر انه رفع ايده بالخطا يا دكتور.
أوكي، حياكم الله. طيب، شكرا لكم. نشوفكم إن شاء الله بكرة. يعطيكم الصحة والعافية. شكرا، في أمان الله.